Thank you, Leon, and thank you to the organising committee for inviting me. Genuinely flattered and pleasured to be here. As Leah says, it's interesting times, right? As I understand it, both Trump and Harris will be in Pittsburgh on Monday, within a mile of here. So for me to get your ear at this time is some competition there. So thank you. And yeah, the future of the world is in local people's hands, so no pressure there then. Right, so this is the title. Clearly, this is what I'm here to talk about. Well, mostly it's a title. There's a little subheading put in there, which I cheekily snuck in afterwards, because when I was asked some time ago, I gave a title, but I hadn't really thought through what I was going to say. Now I have, you'll be glad to know. But there's this subtitle, and the role of CBT, which I want to hold in mind throughout the talk, partly because it's the way in which I'm trained. I'm very aware, of course I'm aware that, you know, CBT has a lot of people in this room, I'm sure, have a number of concerns, anxieties, or even an outright dislike of CBT. So I want to hold in mind and respect that. When I get to have conversations with people that have concerns about CBT, I often find that when I hear them, I share their concerns. And actually, you know, the kind of CBT they're worried about is the kind of CBT I would be worried about as well. So I want to, yeah, hopefully not in an evangelical way, but I want to express where I'm coming from in terms of CBT to see where the common ground is and where it isn't, so we can have an open conversation about that. But yeah, if you do have a concern about CBT, then I'm really glad you're in the room, because, you know, this conference is great. I've never been to a conference which will have psychiatrists, psychoanalysts, CBT therapists, social workers, psychologists, all at the same conference. Of course, they're going to come from different perspectives, but to share that and discuss that with each other is a great opportunity, rather than just remaining in our little bubbles and not challenging ourselves, which we are inclined to do, which is a theme of what I will talk about as well. So anyway, my version of CBT, as I'm going to hold in mind for this morning, is that really. Those of you at the workshop will have seen that. I'll let you have a little look at it. What are you seeing there? To me, embedded in this is everything about CBT. There's a bunch of lines, black lines, there's a green square. Maybe the green square's at the front. Maybe it's not. Maybe it's at the back. Only you know, because that's an internal experience in your head, depending on how you perceive that shape and what depth you've given to it. But now I've said it, you're thinking, well, I see it at the front. Maybe you can see it at the back. Maybe I can do that. So yeah, try and flip it from one to the other. And I'm guessing you can, but it's not that easy. Embedded in there is everything to me about what CBT is. There is no objective truth. I'm not going to tell you whether it's at the front or the back. You can experience it in completely different ways, and that's fine. You can change your perspective from one way to another. It takes a bit of effort, though. It's not completely easy. And that's also a kind of embedded principle in CBT. But fundamentally, there's no objective truth. If CBT is done in a way in which someone's pushing one idea on someone else, in which there's a right way to think, it's challenging someone else, then as far as I'm concerned, it's being done badly. CBT is exploratory, it's compassionate, it's based on helping someone explore the way in which they make sense of the world and discussing it if they choose to do so, if they have a motivation or a wish to do so. Now, of course, that's easy for me to say, because even if you don't mean to, you can find yourself imparting your worldview and it influencing someone else. But of course, that happens in daily conversation. We do it all the time. That's not the monopoly of CBT's problem. That's any therapy or any conversation. We're always influencing each other. So yes, that can happen. But that's not a problem just with CBT. It's based on assumptions and biases. We all have them. We all have them. We live in our bubbles. We don't particularly like being challenged because it's a bit hard and we don't want to just give up on what we believe every day. It's too hard. We go around typically full of biases that confirm exactly what we believed yesterday is the same thing we believe tomorrow. And that's okay. I'm not here to pathologize that or say that's a problem. It's what we all do. That's fine. Well, it's usually fine unless there's a problem, and then maybe it's not fine, but that's up to you. It's up to you if you want to explore your assumptions and biases and check out where you're coming from and think about it. And this is all going to apply to trauma, but I'm just setting out the scene to begin with. You know, if you have a dog phobia, CBT is really good at telling us what's wrong. You predict the dog will bite you. You don't know the future, you don't know for sure, but you predict that. And of course, if you predict that, you're scared and you'll run away. That makes complete sense. It's a very normalizing approach. How you feel, how you behave makes complete sense if we can identify how you think, more importantly, the predictions you make. And why do you make those predictions? Well, it's a hypothetical person, but I'm sure you're guessing the same as me. You ask the right questions and you'll hear a story where it makes sense. There'll be a reason someone predicts that dog will bite them. Something's happened to them, either directly or indirectly, but they've learned something that's influenced their predictions, and it makes sense, you know? And that's the words we should always be using in CBT. It makes sense. Not you're wrong, not I'm here to change how you think, but how you think makes complete sense. But it's up to you whether you want to think about whether the impact of your fear of dogs is having an impact on your life that you want to explore or not. Like I say, we're all full of biases and assumptions, and that's okay. We should always try and challenge it when it's relevant, and professionally we should try and challenge it. So there are other assumptions that are deeply embedded in people's thinking, including my own, of course, but I'm just highlighting a very powerful one that has an influence on our field. But I'm pointing out what I think is uncontroversial, which is an assumption. There's no proof. It's not a fact. It's an assumption, and people who hold that assumption are going to be hard to have it challenged because they're going to experience lots of biases that maintain that belief, just like we all do. So I'm just putting that out there as well. So there's an assumption. Okay, we all have assumptions, like I say. I can't prove it right or wrong, certainly not this morning, but it's an assumption. Let's take that. A little example of how I see, you know, I don't mean to, well, maybe I do mean to. I don't know. Let's put that out there. Am I holding up the medical view for a particular critique? Maybe I am, because it's particularly powerful. But it engages in these assumptions, and I see this everywhere. I see it in the scientific literature. Joanna Moncrief, a London-based psychiatrist, doing a lot of good work challenging the assumptions made behind the use of antidepressants, and doing this review on challenging the serotonin hypothesis. Yeah, good work, good challenging work. And the response from some of the medical community, well, we never believed in the serotonin hypothesis anyway. It never was that simple. We knew it was always more complicated than that. The goalposts move and nothing changes. So yeah, I am taking a critical look at that approach, whilst recognizing we're all vulnerable to engaging in the same way of shifting the goalposts and keeping what we believe close to our hearts. So I'm putting forward another assumption. I would say it's an equally valid assumption. I understand I can't prove it factually right or wrong this morning, but I'm putting it forward as a useful assumption to explore. And I'm recognizing that one of those assumptions is supported by a billion-pound industry and the other one isn't. And, you know, I'm sure you can guess which way around it is. So let's work with assumption number 2. But there are things we can learn from the medical model, of course, and the kind of metaphors that we can build on from the medical model. So I just want to spend a moment thinking, holding on to the medical model, holding on to the language for a second. I want to take a look at that as we did in the workshop yesterday. So you'll look at that, and we can use the language of symptoms, and we can say there's a skin abnormality there. We want to get rid of the symptoms to kind of cure someone, and you might do that by getting rid of the blister. You've got rid of the abnormality, you've made the skin look normal, and you've dealt with what you see as the symptom, what's the illness. And, you know, a lot of us will be thinking, ooh, no, don't do that. You know, might be tempting, but don't do that. Because we know that blister is there for a reason. Underneath that blister, there'll be some kind of skin vulnerability, something that's happened. The blister's protective, it's protecting what's underneath. May look a bit unsightly or whatever, but it's not there randomly. It's there for a reason. It's actually got a protective function. So don't burst it. Think about what it's protecting. Or at least if you are going to take it away, think what you've done. Think what you've left behind. Think what vulnerability you've left behind. And I'd like to take a look at that and think the most well-informed physician would also think, well, what's going on with the shoes here? What's the bigger picture? You know, if we treat this, is the shoe just going to create another one? Maybe we need to be thinking about that as a level of intervention. And maybe we want to think about why that person can't afford shoes or good shoes, etc. So I want to hold on to all those lenses and recognize the importance of them. And holding in mind the tension or the debate that we need to be having about the role of different levels of intervention and what they mean to each other. And that's certainly the case in the world of trauma, obviously, the social, political context of trauma and the implications of the kind of treatment that we do. Okay, so like I say, and I'll hold in mind the idea of the different levels of intervention. Because what I'll be talking about is very individual work, one-to-one work, which can understandably and rightly be critiqued for putting the onus, putting the responsibility on the individual in some way without recognizing the political context. And I don't think it has to be like that. But this is an issue for all of us to think about, how we work with individuals whilst holding in mind the context in which that person lives and the influence that has been had on them that contribute to what they're suffering from. And we need to think about power, of course. In all of that, we need to think about power. We need to ask ourselves the question, well, you know, in our worldview, we think we're doing the right thing. We're doing a treatment. We're doing what we think's right. But if we advocate that treatment, if we pursue it, you know, let's step back a bit and ask in whose interest that is. That's kind of easy to do historically. We can look at that and be a bit shocked. But it's real, not so long ago. And it's easy to, you know, critique that now. It's a lot harder to do it in what we're doing right here, right now, right in front of our own eyes. But that's our challenge for all of us and for me as well. And, you know, I like to think CBT is both potentially a victim of that, but also something that can work with it just as any other approach can. It doesn't have to be a victim of it. Can we have socially, politically informed CBT? Okay, so just going back to the idea of the function of the blister and the function of mental health symptoms, I want to hold that in mind and come back to it, that anything that anyone is suffering, to use the illness model as a symptom, is there, not randomly, it's there for a reason. You hear their life story, you hear what's happened, and it makes sense. Whether it be feeling under threats or cutting off, or having a personality style that predisposes you to being aggressive, it all comes for a reason. It all comes from a life story. It all makes sense. And I'll argue that's true for paranoia and voices, to use the kind of psychosis illness language as well. Very quickly, we can think about that in terms of paranoia and in terms of trauma. And when I'm using the word trauma here, I mean very general trauma, childhood adversity in general. Later on, I'll use the word trauma more specifically in relation to how it's used in the PTSD world for the kind of trauma that gives rise to intrusive memories. You can, of course, suffer trauma if we use the word generally in a way that doesn't give rise to trauma memories. Later on, I'll be focusing on trauma memories. But at the moment, it's general. But yeah, paranoia is basically a threat belief, isn't it? It might be one that people think is unusual, bizarre, completely wrong or whatever, but underneath it's an emotional experience, it's anxiety, it's threat, and it's maintained through the threat system being on high alert all the time and hypervigilantly looking out for that threat. That much we know, a simple theory, but a powerful one that's maintaining it and hard to change. But yeah, we can make sense of that. We hear about people's life story. This paranoia didn't come out of nowhere, or certainly the underlying emotional predisposition to feel threatened and not feel safe didn't come out of nowhere. You hear the life story and it makes sense. And you hear that life story in a wider social political context, it makes even more sense. But yeah, let's keep it simple and generalize. All these things that are called symptoms are there for a reason, and they're typically there for that reason. We all do it, you know, we all want to be safe. We don't want to experience harm. Some of us are more vulnerable and sensitive to thinking that's going to happen to them, and we'll respond in very different ways. We might go on the attack, we might hide away, we might avoid, we might cut off, but they're all fundamentally aimed at helping us try and keep safe. You know, and if we had a society where everyone felt safe, we wouldn't have a need to be here, would we? So, you know, our role as therapists, generally speaking, I think, in all, perhaps all approaches, but certainly I would say in CBT, is we want to understand that function. If we're not, we're doing someone a disservice. We're just slicing off a bit of them and putting it under the microscope. We understand them as a whole. We understand, to use the word symptoms, where they've come from and why and what function they're serving. Because if we just try and take them away, well, we're exposed to what's underneath the blister. But in terms of therapy, of course, we help people think about, if they wish to, collaborative, their choice. We help people think about, well, it makes sense. It makes sense that you would think this, behave like this, whatever. And it certainly makes sense at one point in your life, but is it working for you now? And that's up to you to think about and decide. But, you know, things have changed, your context has changed, but you're still behaving in the same pattern. Is that something you want to think about? Maybe it's time to think about, yeah, updating the situation, and whether you're getting your own needs met and whether you want to challenge yourself, that's up to you. So let's come back to trauma and where this fits in with that. So jumping back to this question, I'm putting it up there, and you know I'm not going to be able to answer this, and I'm not going to try, because I'm not going to play that game. I've been to many conferences, and the ones that are mainly biologically based. You know, when the conversation turns to this topic, there seems to be a responsibility for the people from this camp, if you like, to prove it. Yeah, go on, prove it, you know. Of course, you can't prove it. Proving causality, that kind of proof is extremely difficult. So, from my point of view, the question is, well, why? Why should it have to be proved? The illness model hasn't been proved. That doesn't stop billions of pounds of investment. So, you know, I'm not going to play that game. That said, there is some research. Of course, there's usefulness research, but you know, it's longitudinal research, and it's large scale and difficult to do. But yes, some evidence that the more childhood adversity people experience, the more likely they are to develop psychosis. Shock, who knew? That's maybe the more interesting question, certainly for me, and I assume for you. So that's what I'm going to focus on thinking about, the different kinds of relationship and how we can understand. And we've already talked about one of those, adverse life events giving rise to threat, a sense of lack of safety and threat that can, at its extreme, turn into things that people call paranoia. So what do we know? Well, we know what you know, that there's a high level of trauma, however we define that word, whether generally or specifically, there's a high level of trauma in people diagnosed with a psychotic disorder. We know that. And we know it increases the likelihood of people having that childhood trauma, increases the likelihood of being diagnosed with a psychotic disorder. If we think about it diagnostically, if we work within that world, that diagnostic world, then roughly maybe 15–20% of people diagnosed with psychotic disorder are also diagnosable with PTSD. And I say diagnosable because most of the time they haven't been diagnosed, because no one's asked them, no one's assessed it, and the whole psychotic world is the thing that distracts and gets all the attention, and the underlying trauma is ignored. But in our research and others, around 15–20%, which is, you know, 15–20%. There's a lot bigger percentage, in fact, the majority, I'd argue, that, again, to use that language, have subclinical PTSD symptoms or reactions. They might not meet the threshold for PTSD, but they have experienced trauma, and they've experienced the consequences of it, and they're still suffering from it. So that's the bigger group, and perhaps, you know, arguably the even more important group due to size. And I think, you know, maybe, I don't know, kind of jumping ahead to the last line of what I'm going to say, but I'll say it now anyway. You know, I look at that and I ask myself, well, you know, it shouldn't be for us to kind of talk about, should we be treating trauma and psychosis? We should be saying, we know people diagnosed with psychosis have suffered trauma. We know trauma affects people. We have evidence-based treatments for PTSD. The question is, why aren't they getting them? Why are they denied access to treatments that other people would get? We know that interpersonal trauma is particularly toxic, more likely to develop PTSD than, for example, natural disasters or certain kinds of accident. The interpersonal element and the kind of emotions that go with that are particularly toxic. So PTSD is not all about fear. It's not all about thinking I'm going to die. There's the interpersonal element and the emotions that go with that, the guilt, the shame, the humiliation, the disempowerment, the emotions that are so highly associated with childhood trauma and so highly associated with people that are struggling with psychotic experiences. We know that interpersonal trauma is indicated with a lower recovery rate from PTSD. So again, you know, a particularly kind of toxic form of trauma. So yeah, I guess for myself and lots of people I've collaborated and worked with, I mean, you know, we haven't all got together and got in a room and come up with a mission statement, but if we did, it would read like this. And yeah, we want to push the boundaries, we want to push the debate, we want to keep pushing. And yes, I know that this model doesn't fit everyone and explain everything, but like I was saying yesterday, I don't lose any sleep over that. I don't really think that you know, I'm going to wake up tomorrow and the world will have listened to me and dropped everything else and just pursues this. So that's not a danger. You know, pushing an agenda, knowing that there are other powerful people and organizations pushing other agendas. So to show some of them, because, you know, none of us are individuals. Well, you know, we are, but we're not. We're connected, and my work is connected and has been built on the back of others from various countries that pull together expertise in both trauma and psychosis and the Hearing Voices movement, which I'll come to later. So I've talked about trauma definition. That slide was just to remind me to do so, if I hadn't already done so, because it can get confusing. What do you mean by the word trauma? It can be used very generally, but from now on, I'll be using it in the more PTSD world, the kind of trauma that gives rise to the intrusive memories. And it's those intrusive memories that are now the focus for me and what I'll talk about, the kind of, the reliving, the intrusive, involuntary experience of that memory coming crashing back in on you. So in the time I've got, I'm going to try and highlight two particular approaches, starting with this one. How we make sense of fragmented trauma memories and what's that got to do with psychosis. What do we know about trauma memories? Well, we know they're all those things. You know, this is in general, outside of psychosis. They're intrusive, of course. They're vivid, they're emotional. It feels like it's happening again now. The brain can get confused about the past and the present. That's the dissociative flashback experience. They're multisensory. They're not just visual. They're in all modalities. Sometimes they don't have any visual or auditory component. The body can experience the pain of a trauma without any other modality coming in. So yeah, they can be very fragmented and they can be very confusing regardless of what diagnosis you end up with. In the UK, we tend to use this model, which I'm not going to go into massive detail other than to highlight that it's a model that refers to the way in which we process information at the time of trauma, helping us understand why we re-experience it in the form of current threat. To do with the way in which, to refer back to the theme of things having a function, people respond during trauma in a functional way. They respond in a way that might save their life or protect them. They might need to respond quickly to press the brakes on the car, so they need to kind of engage and process information fast. Or they might, if they're being sexually assaulted, their body might shut down in an involuntary way to protect themselves, a kind of playing dead response. People often struggle with that later. People often struggle and are angry with themselves about why they didn't fight back, why their body didn't seem to do what they wanted it to do in hindsight. But it's understandable when we think about it, when we think about the function of what was happening was trying to save someone's life at the time. So there's a function, there's a reason, but we pay a price for it later. The way in which that information or the body responds at the time makes sense, but we pay consequences for it in the future. And within the PTSD world, we pay a consequence that the memory, that what was happening at the time wasn't processed in a full way, and it leads rise to these PTSD memories that are involuntary and vivid. I know that's a very brief explanation, forgive me for the lack of time on that. A lot of you will be familiar with it anyway. But when you have these intrusive memories, you respond within the cognitive behavioral model, you have beliefs about them, you behave, all the things that make sense to make yourself feel safe when you're under threat. But the threat comes from the memory. It's not like an anxiety, it's not like a dog phobia, it's not the dog's going to bite me in the future. This is a memory from the past. You go, well, why is that bothering you? It's past, it's happened, why is it bothering you? It's bothering you because you relive it as if it's happening again now. It has current threat, but not just threat. You relive the emotions. And in childhood trauma, these are often emotions of guilt, shame. You relive those as well, as if it was happening now. So that's a phrase from the work that we refer to in the UK, and it kind of embellishes what I'm saying about trauma memories being decontextualized. We re-experience them without that time and date stamp of knowing where it belongs. And the brain's confused, and it kind of feels like it's happening again. Very intense, very distressing. They're not always accurate, okay? They're not always an accurate representation of what happened, which is a big one. Talking yesterday, people concerned that, if people are so-called deluded and, maybe they're having these memories of things that didn't really happen, so what do we do then? Because that isn't real, and what are we actually treating? And my answer to that is, don't worry about it. It doesn't matter. It doesn't matter in as much as what doesn't matter is our efforts to try and know whether it really happens. How are we ever going to know that? They're having memories of it, whether or not we think it happened or not. So it fits the PTSD model. If they were so-called paranoid at the time and the threat wasn't real, it doesn't matter. They're getting memories of it, and that's your treatment target. It is not the monopoly of people diagnosed with psychosis that their trauma memories are not accurate. Often trauma memories are not accurate. I don't know whether the Grenfell fire made any news here in the US, but it was a big event in London. It's a tall tower block in London, in one of the richest parts of London, Kensington, and it was mainly habited by immigrants and people struggling with poverty, and cladding was put all over it. Not for them, but for the neighbors who had to look at it. Cladding was put all over it to make it look nice. That cladding wasn't fireproof. People cut corners, they did it on the cheap. When the fire broke out there on one floor, the fire service did what they had been trained to do, which is tell everyone to stay in the flats because they should be self-contained and protective. No one accounted for the fact that the fire would shoot up the outside through the whole cladding and 80 people would die. So that was several years ago, and the political fallout is still happening. And it's an example of trauma in context. That fire should never have happened, but it was so massive and so many people suffered. The NHS set up a new service, the Grenfell Trauma Service, to work with that, a service that should never have been needed. But it was needed. People suffered, and a lot of trauma work was done. And, one of the bits of research that came out of that was the high level of seemingly inaccurate trauma memories. People were suffering from things they thought were going to happen. They thought they were going to die, yes. They also thought a loved one was dying at the time they were being traumatized, and subsequently would have trauma memories of the loved one dying, although they didn't die. And they know that because, it's a year later and they're still in their life, but they're still having trauma memories of that. So the fact that we have trauma memories of things that didn't actually happen is widespread and not the monopoly of people diagnosed with psychotic disorder. The fact that trauma memories can be highly confusing is a kind of given. Yes, sometimes it's a discrete car crash and you have just memories of that, but for childhood trauma, that's often not the case. Repeated, prolonged, multiple traumas give rise to lots of very fragmented memories that can be highly emotional and highly confusing as to where they actually came from. Identifying it as a memory is not necessarily an easy task. If you don't identify it as a memory, well, then what? There's the big question. Then what? And if you don't know it's a memory, how is the person opposite you going to know it's a memory? And, you know, I'm just here to put out the possibility of these things becoming confusing and the different pathways that that can lend itself to. It can get very confusing. Lots of traumas, lots of reactions, lots of emotions, lots of confused connections between what happened to someone and the kind of memory they're experiencing. So if that happens, and we're not thinking it's a memory, yeah, we're not saying instantly, quickly it's a memory, then what are we going to conclude? So I want to make reference to this as just one, it's not the only, just one lens in which to think about this. And I want to be sure to make clear that I'm not pathologizing anything that would be considered schizotypal within this approach. By schizotypal, we mean within the medical model, things that would be kind of arguably diluted forms of unusual beliefs or experiences. Things that don't need clinical attention, things that are part of a natural personality style, things that can overlap with cultural and spiritual beliefs. So I want to be very clear, this is not a pathologizing view to these things, but it is, and there's a couple of questions. If you're going to measure this in a questionnaire, you can imagine you might well answer yes to those things. And that's not a problem, it's not any kind of pathological issue. But what do we know about this group of people and their reaction to traumatic life events? Well, we've done a whole bunch of studies basically saying that this personality type are particularly vulnerable to having more frequent and distressing memories of traumas of different kinds, done in experimental laboratory situations, to PTSD clinics, to following up people after road traffic accidents, whatever, the same result. And a quick anecdote that I always remember from one of the first studies back, crikey, 20 years ago. This was a laboratory one, so it was people like being, volunteering to be exposed to an analog trauma. It was watching videos of fire service footage of crashes and the aftermath, quite intense, enough that people might have intrusive memories of it in the following week, as we often do if we see something distressing on the news, for example. The job was to record those memories in a diary and come back in the study. Anyway, I just remember this particularly vivid discussion I had with a guy, and he talked about, so during the week, I had this really weird experience. I was talking to my girlfriend, and I was just talking to her, and I was seeing her in front of me, and then I kind of saw blood all over her face. But, I knew I was doing this study, and I remembered the video, and I've been doing this diary every day and writing stuff down, and I could see that, it kind of was like a memory of the video. So, there you go, memory. And, this is just early work I was doing, and that just sticks in my mind as, okay, well, there's the blurred boundary, right? Was that a memory? He says so, end of. What if he didn't think it was a memory? I mean, that's pretty vivid. That's kind of an integration of your memory with your current perception in a way that can be very confusing and lend itself to a wide range of different conclusions you might come to about that. So we come up with this model, which I'm not going to go into lots of detail about, other than to highlight the spine of it, which is the relationship between this personality type. And again, I'm not pathologizing, but schizotype personality, people that might believe in clairvoyance, telepathy, so-called paranormal beliefs, absolutely fine. I'm not here to judge that. Just drawing the link between those beliefs. And if you are having distressing, fragmented, confusing trauma memories like that guy with the blood on top of his girlfriend's face, maybe it would make sense. You're going to, like us all, you're going to make sense of things within your own worldview. If you already believe in telepathy, then this is telepathy happening now. Someone's putting this in my head. And maybe you start coming to conclusions about this being not a memory, but a premonition, a warning about some threat in the future. And when you start talking like that in certain clinic rooms, different conclusions are going to be made about what you're struggling with that are not based on trauma. So I'm putting it out there as a possibility, something to consider, something to hold in mind when we're working with people clinically. Again, things can get very confusing. We need to be mindful that we're not imposing our view on people, but our job is to hold in mind different possibilities. What does that mean about interventions? Well, it means we pay attention to those fleeting moments that are highly vivid and distressing for people, and the way in which they make sense of it can have such big consequences for the rest of their life. And from a collaborative, proper CBT point of view, we are just open-minded to explore what goes through their minds and how they make sense of it, and raise different hypotheses. The trauma model, which is one possible hypothesis. So far, we know there's high levels of interpersonal trauma. We know a lot of people, if they were assessed with psychotic disorder, would also fit the PTSD diagnosis. And like I said, we know that PTSD treatments work. So why aren't people getting them? You've got these guidelines for PTSD in the US. They're pretty much CBT based. They're slightly different, but not that different to the ones in the UK. Pool our nation's guidelines, and they refer to the same kind of interventions. And those interventions, what they have in common is memory-focused, memory-targeted work, needing to pay attention to working with the memory, to bringing back the memories and updating them and working with them. Why are people excluded? They're excluded for a whole bunch of different reasons. And, you know, that's not meant to be all of them, but, well, they've been excluded from the clinical trial. So you can say, well, there's no evidence, so that we can use that. There's this stress sensitivity, you know, good research, of course, recognizing the role of stress in relapse psychosis, but it actually becomes a hindrance when it's used to say, these people are too vulnerable to engage in any kind of emotional work. It'll make them relapse. Now, I'm not trying to say it's impossible that that can happen. I'm just saying that it's an assumption. And let's go back to the fact, where do we get our assumptions from? And when do we challenge them? And when do those assumptions get challenged in a way that changes things? Through research. Our research tells us that that's not the case, that people are not relapsing when we do this work. I can't speak to the ego being too weak. I'm not trained in that approach. I'm aware that that has been used as a reason that people shouldn't engage in therapy in general. And people, if they're not familiar with it, they can feel very threatened by dissociation. You know, and I guess I'm here to say, don't be threatened by that. It's part of a trauma response. It happens. We know how to work with it. We can deal with it. And, you know, I was hearing yesterday people talking about they work in psychosis services and they've got a PTSD service in the same building and they never talk to each other. Do talk to each other. You've got so much to learn from each other, and you put your minds together and you can do something great. So I'm going to talk very briefly about imagery rescripting, because it is the trauma approach that we have found most useful in our UK trial. So there isn't time to show a video of this. I just want to hopefully whet your appetite to kind of, you know, find out more about it. It was an approach developed in Holland by Anno Arndt, particularly to working with childhood trauma and thus its application to psychosis, where so much childhood trauma exists. In brief, like I said yesterday, you kind of do this already. We all imagery rescript. Hold in mind, imagery is a very powerful medium within which to experience life. When we think about things in an imagery modality, it carries a lot more emotion than just thinking words, yeah? So the example I was giving yesterday is like, there's a different term in America, but I've forgotten already. But in England, if you're driving and someone cuts you up, they just, you know, they cut in front of you in the car, they piss you off, and like, you know, you're annoyed, and they're arrogant, and not only do they cut you off in the car, they flip a hand sign out the window and shout something and drive off before you've had a chance to restore your position in the world. You're left feeling a bit bad, and there's nothing you can do about it because they're gone. It'd be completely normal, I think most of us would do, driving along, kind of feeling a bit angry, and you kind of relive it in your head. You relive it in your head, but this time they don't get to drive off. You kind of say something clever and brilliant that puts them in their place, and you feel, yes, I'm on this. They didn't get one over on me. I am empowered. And you've done it. You've relived that experience. You've given it a different ending, and you've met your emotional needs. And that is what imagery rescripting is in a day-to-day level. And I know that sounds a bit trivial, but it does apply. It does apply to any kind of trauma. We use this approach. We relive the trauma, and we allow ourselves to have a different ending to that trauma in a way in which people meet their needs. Like I say, it's important to engage in the imagery. That's very powerful. And it's important that that it's not just in the head. I was hearing and understanding that, yeah, yesterday in the panel talking about a therapy that's just in the head. Absolutely, I agree with that. This work is not just in the head. When you're reliving that trauma, you're not just getting people to say what happened, you're getting to relive it and feel it. It's felt in the body, the emotions are coming back, they're engaged. And then when you give it a different ending, it impacts everything. And you get up out the chair. Yeah, I mean, particularly if this has been sexual assault and people feel disempowered, they need a rescript in which they feel empowered. They get up out the chair and they act out what they need to do, and it crosses over with the body work people have talked about, because the body is responding in a different way to how it did. You know, when it closed down and shut off during that trauma, it does absolutely a different thing when you relive it. It gets up and it empowers itself and it shouts and it takes control. And you feel it in the body, and, you know, perhaps crosses over with drama therapy and other ideas. And that's great. But, you know, just to make the point, it's highly emotive, it's highly real. It's not just sitting there talking about it. And it's a good idea to tell your receptionist when this is happening, because it can sound like all hell is breaking loose in that room, and they need to know. Yeah, and the rescript is based on people's personal needs, and they are the person to develop it. They are the person to say what the rescript should be. We had an interesting conversation yesterday, but you can think about for yourself about how you feel about violence being part of that rescript. Different people have different views on that, and if they have anxieties, it's for different reasons. If the anxiety is a fear that if they do it in the room, they'll go out and do it for real, then, you know, we have found that that does not happen. There's no evidence of that happening, but you may have other sort of moral discomforts with it, which would be interesting to think through. For myself, and I'm okay with it, and people feel very empowered. I think, you know, what matters for that profile of trauma is people have a rescript in which they feel empowered, and there are different ways in which they can achieve that. But feeling empowered is massively important. And we find this works better with childhood trauma for the reasons that Arno Arntz put it forward, that you're not just reliving the trauma, you're changing it in a way that can be empowering. It feels more positive to work with in the therapy room. And it can be generalizable. You might be working on trauma X, but because you're working on certain emotional themes, those themes apply to trauma Y and Z as well, and what you've benefited from in one bit of work generalizes to others. So we've done quite a bit of work on this. Sorry, this is a sidestep to where, we've done quite a bit. This is Arno's work, and we've done a voice hearing. Sorry, slides in a different order. This is just talking about PTSD work in general. We've done this with refugees and asylum seekers in London, talked about that. And this point, yeah, one of the reasons people feel worried about doing this kind of trauma work, or any kind of trauma work with psychosis, is back to that stress sensitivity idea, back to the fact that people relapse and they're too sensitive. So this is a really important study to hold in mind, the Dutch group telling us that, yeah, of course, in any treatment, in any PTSD treatment, in any treatment, a dog phobia treatment, you know, you get someone to find out whether the dog's going to bite them, their anxiety is going to go up before they find out that the dog won't bite them. So symptoms do, to use the word symptoms, do exacerbate, but that doesn't mean that they're not going to get there. They might take a bit longer, and in fact, the research tells us that they do take a bit longer, but the outcomes are just as good. So I guess for those interested in doing this work, use the research to gain your confidence. The fact that the symptoms go up, the voices go up a bit, the trauma symptoms go up, perfectly dealable with. You get through it, and the outcomes are just as good in the end. So it's not a reason to avoid treatment. Just a reference for you, assuming the slides are available from the talk of a relatively recent review of the area, if you wish to follow up on that. And the evidence so far, that prolonged exposure and EMDR are both equally effective in the Dutch trial in treating trauma and psychosis. Dissociation is threatening. Like I said, we've worked with that and we've dealt with that like trauma people do all the time. It's part of the process. It's not a reason to avoid the work. There's all sorts of ways of doing this. We've used imagery rescripting of voice hearers, and we wrote a paper about how we, you know, used what we already know from the trauma world in working with dissociation. And the same thing, that people who dissociated still benefited from the treatment. They did just as well in terms of outcomes. Maybe it took a bit longer, but they got there. So it's not a reason to think that this work isn't applicable. We've got a large RCT of treating PTSD and psychosis going in the UK, 300 people. It's the culmination of lots of our work over the last 20 years, and right in the heart of that treatment approach. It's a 9-month treatment, just to put this in perspective. It's not massively long-term, 9 months, but the memory-focused work is there, front and center. Phase 3 in the middle. So everything goes through that in order to get to the end. So yeah, just as we know from the PTSD world, targeting the memories needs to be done to be effective. Okay, in the last 10 minutes or so, I just want to highlight you to another approach that we've worked on in the UK and Holland, to demystify it a bit, because I know a lot of people have heard of it a bit. This doesn't fit the CBT model. In fact, I'd say it doesn't fit any theoretical model, and that's a good thing, because the people from whom it came kind of don't want it to, if I understand them right. They don't see the need for it to. But if there is a approach, it's basically the idea that we're all made up of multiple parts of ourselves, something schema work and other therapies have thought about for a long time. And if we have a trauma model that's relevant to this, then it's simply that if you suffer a trauma, perhaps the voice is a dissociated part of yourself. And I want to come back to the idea of everything having a function. So what function does the voice have? If we take the view that the voice is a symptom of an illness that we want to get rid of, well, what happens when we pop the blister? What happens if we get rid of a voice? Why is it there in the first place? These are the questions that are being asked. We know that people who suffer from PTSD, a lot of them hear voices, around 50% mark. This study with trauma in refugees and asylum seekers in London, around half of them suffering from the trauma and also hearing voices. These are people who haven't been diagnosed with with psychosis, because we seem to be okay with understanding that they suffered horrible torture in their home country, so what they're suffering now must be linked. We don't seem to allow that connection when the trauma was in childhood and longer ago and a bit more confusing, but yeah. So the idea of multiple selves and the trauma, the voice is a dissociated part, but the voice is a function. So this approach has got very different premises to an illness model. The voice is there for a reason. It may seem to have been a bad part of your life for a long time. It may seem to have been even telling you to take your own life for a long time. But communication is bad between you and the voice. So how do we facilitate a better communication? This is Eleanor Longden's paper putting forward the role of dissociation and trauma. But like I say, it's mainly atheoretical, and it's come out the Hearing Voices movement, and it's not meant to be overly professionalized or theoreticized. And anyone that's done chair work in a schema approach will be familiar with the idea that, you can use chairs to let different parts of yourself have a voice. And it's simply that. Let the voice have a voice. Give it a chair. Let it speak. Maybe you'll be surprised about what you hear. But just like anyone else you're in conflict with, if you don't sit down at the table and try and communicate, then you're just going to stay in conflict. And if that voice is kind of in your head and part of you, then that's a pretty long, horrible journey that you're being left to work on now. Oh, thank you. That was the guy behind the curtain is going to press the button for me. Thank you. So, quick video to demonstrate this. Thank you.
Child, I believe.
Okay, thank you. So, yeah, 4 minutes, of course, to give you an idea of the approach. A session would normally, obviously, have more preparatory work and take longer, but to demonstrate how an aggressive-sounding voice may be communicated with in a way in which, and you're not to prejudge the outcome, but it's possible that the outcome might be that actually the voice has got a function. It's actually trying to warn you. These warnings can sound threatening. When they've been ignored for a long time, they might sound even more threatening. But actually, maybe the function is there. So anyone that's done any kind of schema work or chair work or anything that connects with taking a different point of view and allowing that to be expressed from different chairs and different perspectives, will be familiar with this approach. It's in addition to that, just giving the voice a chair. Like I say, without preempting the exact outcome, but working on the assumption that perhaps if we hear what it has to say, it might reveal that it's there for a reason, and that reason isn't as negative or threatening as might have been perceived. So yeah, well, you know, this approach, coming from the hearing voice movement, been around for a long time, but when I did some work with Dirk, who was in the video there, and Eleanor Longden, yeah, it was seen as really radical and fringe and scary. And, you know, certainly a mainstream psychiatrist was not happy with this, because what are you going to do if the voice, you know, is empowered by it and tells someone to take their own life? What are you going to do then? And of course, you know, you put things on the table and you explore them. That hasn't happened. You know, perhaps the biggest question with this approach is it safe? And all the work that's been done to date suggests it is safe. As for whether it's effective, the timeline is you know, much further behind than standard PTSD treatments. But Eleanor Longden's doing bigger studies now and has published a guide, a protocol to this work, available, and is now doing a bigger trial, you know, a full RCT, a fully powered RCT to test out the evidence base, funded by the NHS. So, you know, God knows, I live in the UK, I know the NHS has its problems, but one good thing about the NHS is it funds the research and delivers the service together. So there's integration. It's not going to fund this research and then just ignore it. So this is an NHS funded study pushing this approach into the mainstream. So yeah, trauma treatments exist. Let's use them. Evidence says they're safe. Let's question why there are barriers to access for people diagnosed with psychosis. But things change. You know, in my country, early intervention services, standard guidelines, you assess for trauma and you treat PTSD when you find it. Only in early intervention, for some reason, that guideline doesn't apply once you're out of early intervention. But our guidelines on severe mental health problems, PTSD, where present, identify it, treat it, etc. So, you know, things change, and I'll leave you with that message. Thank you.
Thank you so much, Professor Steele, for a really informative session there, really highlighting the importance of trauma and the pathways forward for folks with these experiences. We have 10 minutes for questions, so not a huge amount of time, and we do also have a couple of questions from our virtual audience coming in. How about we take one from the room first? Put your hand up if you have a question, please. Okay. I think what I'll do is, if you shout it out, I'll repeat it into the microphone so people at home can hear. Justin. Okay, I could probably reach you first. Hold on. Just a big room.
Thank you, Professor Steele. My question is one of the challenges linking addressing trauma or adversity or severe stress through this diagnosis of PTSD? Do we need a different diagnostic construct, or would that be missing the point as well?
Yeah, there's pros and cons, isn't there? You know, I mean, I try to, you know, I lean towards seeing all the problems with diagnosis, and yet I work in the clinical world where that language is used and research funding is based on it. So you need to navigate that somehow in a way that you think is ethically right and appropriate. I guess, you know, I don't know whether this answers your question, but I suppose the priority for me is considering that is the clinical world I live in. I aim to encourage the question to be asked of, does a complex PTSD diagnosis fit better here? Because if it does, it's going to open up a very different pathway to someone's life and their treatment options. And, you know, oftentimes, or at least when trauma has been identified at all, people are toying around with whether those diagnoses fit, and the clinician will make a personal opinion that someone else would disagree with. So there's plenty of territory there to get into. Yeah, you know, I know there are pros and cons of every approach, but the implications of the diagnosis are treatment implications that are somewhat bigger than what we can control. So I try to help maneuver people within that. You know, like the the asylum seeker refugee work I talked about earlier, like over half of those people hearing voices, and it's only because in London there is a specialist service for treating trauma and asylum seekers and refugees that people would refer to. They kind of think, oh, they're a refugee, they've suffered trauma, I'll put them there. If that service didn't exist, I suspect many of them would end up on antipsychotics.
Thank you. We're going to take one from the virtual audience now. So May behind the curtain, can you please read out a question from the virtual audience?
So the first question we have is
Speak up a little bit into the microphone, please.
Okay, can you hear me now?
Yes.
Okay, so the first question that we have is, do the same sort of principles for treatment or consideration apply for people who have received a schizophrenia diagnosis and or experience a constant state of some degree of psychosis, which has been triggered by hallucinogenic drug use? As in, are there some folks who experience psychosis and do not have significant or related trauma?
Okay, that's very Wizard of Oz, isn't it? Getting the voice from behind me. So, yeah, well, it's a big question. I mean, let's take the last bit. Yeah, I mean, as I said, are there some people who do not have significant or related trauma? Then that would seem to be the case clinically, but rarely in my experience. And you know, I wouldn't want to deny that. So, yeah, like I said earlier, you know, I'm pushing an agenda, I'm pushing a model, knowing it doesn't fit everyone, but feeling okay with that because we kind of it's just encouraging people to ask the question, encouraging people to do the assessment, ask the questions, don't be frightened to ask it, and apply the treatment where relevant. But yes, I wouldn't wish to impose a trauma, certainly a trauma treatment on someone that it wasn't needed or suitable for. But the risk of that is minimal compared to the other way around of people who do need it not getting it. I don't know whether the answer to the second bit addresses the first, but perhaps you know, a drug-induced psychosis without any history of trauma might be an example of what's being talked about there, where the trauma treatment wouldn't be relevant. The voice hearing parts of self maybe, but that's two different approaches.
Okay, I was already collared by somebody who wanted to ask a question in the audience, so we'll take another in-person one, do one more virtual one, and then we'll have to close the session. But obviously Professor Steele is here, so you can grab him at the break.
Hi, thank you so much for your presentation. It was very helpful. I'm wondering, and this could probably be a whole other conference in itself, but what is the role of antipsychotic medication in this? Would you say that antipsychotic medication would generally be used concurrently to this type of therapy or prior to stabilize, or what might that look like, please?
Yeah, I mean, given the reality of the service we work in, most of the people in these trials are on some medication. We aim to have that stable, just from a research point of view, so that if the medication's stable, then whatever other change occurs can't be argued to be due to changing medication. It must be the other thing that's changing, which is the treatment. So we try and, but yeah, yeah, I know Toni Morrison's done research that tries to get involved in people avoiding taking antipsychotics, but yeah, that's not a world we've kind of got into on the research point of view. Most of them are on antipsychotics. If you're asking me whether they should be, I guess my view on that would be to go back to a CBT model, which is to be collaborative, empower people. They can make the choice. I don't want to stand in people's way. Of course, if they have an illness model, or even if they don't and wish to take antipsychotics, but people, you know, in my experience, people can learn from their own experience how useful or not antipsychotics are and calibrate their own dose. What they don't need is someone imposing that on them, making them feel bad for the choices they want to make, and disempowering them in that way. So medication doesn't have to be disempowering. You know, we all make our own choice about certain medications in life, and antipsychotics should be another aspect to that, I think.
Thank you. Okay, so one last question from the virtual audience.
If it's going to be the next one, maybe we can go to the third one, because I don't have much to say about this one. When I read it, I felt, I'll be honest with you, I felt a little bit embarrassed because I didn't really know much to say, because know that much about these different diagnoses because I don't work in the diagnosis world. And then I thought, no, don't be embarrassed. Just own it and say it. So I don't know. It's made me realize how much I avoid getting into diagnostic labels and what they even mean. So they're not terms I use. So, well, maybe I have answered the question. Is the distinction useful? No, I don't even know what the distinction is.
So the question, because the virtual audience won't be able to see those, is that what was the distinction between schizotypal personality disorder and schizoid personality disorder, and is that therapeutically useful? Okay,
Yeah.
so perhaps we can take the next question, since it has, hopefully we'll have more of a response. So it's, can Professor Steele speak more about the integration of voices in treatment? Chair work appears to be Gestalt informed and was used to identify and demystify menacing voices. What was used to promote integration of the menacing voice with other parts of the self?
Yeah, I'm aware of the Gestalt history to some extent. I'm not trained in it. I guess my view is, I believe, hopefully I'm channeling the voice of people in the Hearing Voices movement here. They don't want it to be embedded in any particular theoretical approach. They don't want it to be owned or kind of have to adhere to the principles or bigger sort of baggage that comes with taking on one particular approach. Yes, it overlaps with Gestalt work, scheme work, overlaps with anyone who in therapy has said, oh, sometimes you're angry. Tell you what, how about sitting in that chair and just let your angry self talk? It's just that, and it doesn't need to be any more complicated than that. So, sorry, I hope that doesn't sound, aggressive or anything. I don't mean to dismiss the question. Absolutely, it has links with those origins, but it doesn't need to be embedded in a way that can be restrictive. You don't need to restrict yourself to saying I'm adopting this approach or that approach. You're just giving the voice a chair.
Thank you so much. I'm sorry we couldn't get to everybody's questions, but we do have a short break after this and want to make sure people can move to their breakout rooms in time, grab a coffee, use the bathroom. Once again, thank you so much, Professor Steele, for coming. And thank you for your 20 plus years of work in this. It's very important. So yes, please get a coffee and make your way to the breakout rooms. We will be starting on time, so try not to be too late.